unmute ourselves.
Good evening, everyone. On behalf of the Mumbai CVP Interest Group, it gives me great pleasure to welcome you all to our live webinar entitled Introduction to the Pathology of Congenital Heart Malformations. Our speaker today is Dr. Ondrej Fabian, and I hope I've pronounced that correctly. He is a pathologist and university teacher from Prague in the Czech Republic. And for several years, he has been working in Motol University Hospital, where he has gained a specialization in pediatric cardiovascular, gastrointestinal, and liver pathology. His main areas of interest include inflammatory bowel disease and congenital heart malformations, producing publications in both spheres. A few months ago, he relocated to the Institute for Clinical and Experimental Medicine at Thoma Mayer's Hospital in Prague and started to work in the field of transplant pathology. Welcome, Ondrej. As usual, as usual, the talk will be followed by a live discussion by our expert panelists. We will also be accepting questions through our Facebook page. So please feel free to post any questions that you would like to have answered. Welcome, Ondrej.
Thank you very much again for inviting me, and you spelled my name correctly, better than me, because it's a very difficult name even for Czechs. So I will start. I think, give me a second. I will upload the presentation. So do you see the presentation? So I hope all of you see the presentation without any problems.
Yes, we can see.
Okay.
Yeah.
Okay, perfect. So we can start. Just to briefly introduce myself, I come from the small country in the heart of the Europe called Czech Republic, and I live in the capital city of Prague. And as it was said, I used to work in the University Hospital of Motol when I gained my specialization. And after that, I relocated in ICAM, in Institute of Clinical and Experimental Medicine, where I have been working for several last months. And I deal especially with transplant pathology, and I'm observed by a huge family of RAM that live there in the region of the hospital. And today we should talk about the congenital heart diseases. Well, we've got, let's say, 45 or 50 minutes, so I cannot go into the details. So this will be more like an overview of the most common and most important malformations. And so I suppose that the vast majority of the information I will provide you already know. So it will be just a recapitulation. And I won't bother you with the epidemiology or with the clinical details. This is the pathological lecture. So I would like to focus solely at the morphology of the individual malformations. So this will be mainly about the pathological anatomy. And we will start with the more simple diseases, and then we will move forward to the more sophisticated and more complex malformations. And at the end, I included one, let's say, bonus malformation, which we will do only in case we will have enough time. And we will start with the holes in the heart, and we will discuss the atrial septal defect. So how it looks like, how it is defined, and how to recognize it. Atrial septal defect is some sort of communication on the interatrial level, which is clear. And we've got several subtypes here. We've got foramen ovale patens, then oval fossa defect, and then we've got sinus venosus defect, coronary sinus defect. And in the previous years, we used to have ostium primum ASD, which is now excluded from this group of malformations, and I will explain why in a few minutes. So, what is the foramen ovale patens? When we go back to the embryology, we all know that during the fetal life, there is a hole between the atria, which is called foramen ovale, which ensures the shunting of the blood from the right heart to the left heart. And this foramen, this window, is closed by a valve, And after the birth, the valve is fused with the rim of the foramen ovale, and the foramen ovale is closed, and the remnant is called fossa ovalis. If this fails, we call it foramen ovale patens, which means that the valve is present, but it is not fused. So in the normal state, the shunt is clinically silent because there is a higher pressure in the left heart, which keeps the valve attached to the foramen ovale. But this shunt can manifest in case of increased pressure in the right heart, typically in the case of some primary lung disease, or it can be a source of paradoxical embolism. If the valve is missing or somehow defective, for example, if there are fenestrations in the valve, we call it oval fossa defect, which means that there is a real hole between the atria, which enables a shunting of the blood from the left heart to the right heart. But still, even this sort of defect is, in a lot of cases, it's clinically silent. It can manifest itself in case of large defect. Sinus venosus defect is something a little bit different. It's a communication between the wall of, usually it's a superior vena cava, very rarely it's an inferior vena cava, and it's a defect between the wall of a vena cava and left atrium. And the coronary sinus defect, it's the same for coronary sinus. So again, it's a communication between the wall of coronary sinus and the left atrium. Osteombromium ASD was excluded, as I said, and I will describe it in a few minutes. But let's talk a little bit about the sinus venosus defect, because it can be a little bit more complicated for imagination. Because in a normal heart, in normal physiological heart, if you would make a hole in this region, if you would make a hole in the wall of the superior vena cava, you would leave the heart. But how is it possible that you enter the left atrium? The sinus venosus defect is in fact much more complex malformation than it seems at the first glance, because two things happen here. The first thing is that the superior vena cava is shifted to the left side, and it becomes, let's say, overriding. So the superior vena cava is moved to the left side, and it overrides the interatrial septum. So that's the first thing. Second thing, there is a partial anomalous return of the right pulmonary vein, which opens usually to the wall of the superior vena cava. And those two things, this anomalous return of the vein and overriding the shiftment of the superior cable vein, create something like a conduit. It creates something like channel that bypasses the interatrial septum. So that's how the sinus venosus defect looks like. So in fact, it's much more complex malformation than it seems at the first glance. VSD, ventricular septal defect, is something similar for the ventricles. So it's the communication on the interventricular level. It can be solitary or multiple. It can affect the inlet or outlet portion of the ventricles. It can affect the apical part. And we subclassify it as a perimembranous, muscular, and juxta-arterial. The perimembranous one is the most common. Juxta-arterial is the rarest form. But this subclassification, it's not artificial. It has its clinical significance, and I will explain why. Well, first, the perimembranous. As I said, it's the most common one, and it can be found in the region of membranous septum. So it's in the membranous part of interventricular septum. Therefore, you will recognize it because it has a muscular roof, but the floor of the defect is a fibrous. And that fibrous floor, that's the remnant of the membranous septum. Muscular has all the rims muscular. So the whole rim of the defect is muscular. And the juxta-arterial, it has a muscular floor, but a fibrous roof. And this fibrous roof is continuous with the origin of the pulmonary and aortic valve. And as I said, this has its clinical significance. For example, imagine that the surgeon decides to close the defect. And if the surgeon faces a muscular defect, he or she can quite easily stitch it. But if the surgeon faces the juxta-arterial defect, for example, he or she needs to be very careful because he can create insufficiency of the valve. So this defect is much more complicated for the surgical correction. This is how it looks like. This is one of the hearts in my museum, let's say, and this is one from the larger hearts. And here you can see the opened right ventricle. There is a tricuspid valve. This is the pulmonary trunk, and here's the defect. And this is the perimembranous type, and this is the typical localization because it's usually hidden below the septal leaflet. So if you perform a dissection of the heart, it's good to actively probe this region because there can be small VSD that is hiding beneath the septal leaflet. So it's good to actively search for this location. And here you can see the example. This is the other defect. This is the open right ventricle. And here's the defect, which is quite far from tricuspid valve. And here you can see that the floor is muscular, but the roof is continuous with the origin of the semilunar arteries. So this is the juxta-arterial type. So this looks slightly different. And the last thing, it's necessary to bear in mind that some defects can be very close to the conduction system. This line is the conduction system, and you can see that it goes very closely to the bottom of the perimembranous defect. So again, the surgeon needs to be very careful when closing the defect because he can very easily damage the conduction system. So again, the subclassification of the VSDs has its own clinical significance. And the last hole in the heart we will discuss, it's AVSD, which is atrioventricular septal defect. This sort of defect can be a little bit more complicated for imagination because usually we understand it as some sort of channel with the defect on the lower part of the atriums and upper part of the ventricles, which creates something like channel that that connects all four chambers of the heart. This is true just partially, because the real definition of this defect is slightly different. And it looks like this. The real definition of AVSD is one common AV junction. So instead of separate tricuspid and bicuspid valve, we have just one common 5-cuspid valve. So this is the heart, this is the view from the top, this is the right side and left side, this is the pulmonary artery and aorta. So this is the ventral side, this is the dorsal side. And the AVSD is defined as a one common AV junction. So one common fibrous annulus instead of separate tricuspid and bicuspid. So as a result, we have one common 5-cuspid valve here. And this valve has two so-called mural leaflets on the right side, one mural leaflet on the left side, and two leaflets which we call bridging because they bridge and override the interventricular septum. And the shunting on the atrial and ventricular level, it is usually present, but it is not the rule. The real definition is this. This is the typical disease that is, or typical malformation that is associated with Down syndrome. And this is what I was talking about. Usually we see this. So usually we see this subtype. So there is a one common AV valve, and there is a communication on the atrial and ventricular level. But this is not the rule, because we can have a communication on the atrial level only, ventricular level only, or the septa can be even intact. But still, we call this AVSD because there is a one common AV junction. So this is the real definition of the disease. And if you look more closely at this disease, this can very easily look like atrial septal defect. And this used to be called septum primum, ASD. But if this was really ASD, there would be a normal tricuspid and bicuspid valve. But instead of that, we do have one common AV junction. So that's why this is the reason why the septum primum defect was excluded from ASD category and include it into AVSD category, because there is not only communication on the atrial level, but there is one common valve, so which defines AVSD. So this is the reason why it was excluded from ASD category in some years ago. You can see it here. This is not a good picture because it's a little bit shifted, but this is the open right ventricle. There is a superior vena cava. This is the AV valve, and this is the ventricle. So this leaflet is a mural. This is the dorsal mural. This is the anterior mural leaflet, and here you can see the bridging leaflets, which bridge or overlay the ventricular septum. And here you can see a communication on the atrial and ventricular level. So this picture, which you are looking at, it's this type. But that's not all, because there is one other thing that aggravates the clinical presentation of the disease. Because normally, if you would look into the left ventricle, you can see it here. This is the picture of normal left ventricle. This is the inlet, and this is the outlet portion. And in normal state, in a physiological state, the inlet and outlet portion are approximately the same. The length of the inlet and outlet portion is approximately the same. Because in a normal state, if there was a tricuspid and bicuspid valve, in normal state, the aorta would be almost in the middle. So in a real situation, the aorta is almost in the middle of the heart. But because of the one common valve, the aorta is pushed frontally, is pushed to the front. And this leads to the elongation of the outlet portion of the left ventricle, which can aggravate the disease clinically even more. And this change has a typical appearance at the sonography or at the angiography, and it looks like a gooseneck. So the heart in the shape of the gooseneck is a typical appearance of AVSD at radiology. And we will slowly leave the holes in the heart, and we will move to the most common cyanotic disease we know, and it's called Tetralogy of Fallot. I suppose that we all know what belongs to Tetralogy of Fallot. There is a pulmonary stenosis, hypertrophy of the right ventricle, VSD, ventricular septal defect, and overriding aorta. But all those four changes are in fact secondary changes to one single congenital malformation. They are secondary to one single embryological change. And it's like this. So this is the normal heart. So let's recapitulate the normal anatomy just for a second. So this is the normal heart. This is the atrium. There is a tricuspid valve. This is the normal right ventricle. This is the inlet portion and outlet portion. And normally there is a structure which is called septomarginal trabeculation, and it continues as a moderator band. It's a big trabecule that contains right bundle of Tavar, and it's a typical structure for the right ventricle. And normally it looks like letter epsilon. It looks like Y, because it has two branches or two limbs. The upper limb, which is in contact with the origin of pulmonary valve, the lower limb, which is in contact with the membranous septum. In this region, there would be a membranous septum. And then the limbs continue as a moderator band, and the moderator band continues as a anterior papillary muscle of the tricuspid valve. And between the limbs, there is a small septum or crest, which is called outlet septum of the right ventricle, which is quite small. Usually it's very small, just a few millimeters. But look what happened in case of tetralogy. So this is the normal septum that sits between the limbs, and this is the tetralogy. So the septum is big. There's a hypertrophy of the septum, and there is also a deviation of the septum. So the septum is shifted, it's moved to the anterocephalad way, which means it's moved a little bit to the front and a little bit to the up. And this hypertrophy and this deviation of the outlet septum, look what it caused. It caused subvalvular stenosis of the pulmonary trunk. So we've got first thing. Because of that, the heart needs to pump the blood against the obstacle, and it leads to the hypertrophy of the right ventricle. So we've got second thing. The blood needs to find different route, which is VSD. So we've got third thing. And this deviation, this shiftment of the outlet septum pulls the aorta to the right, and the aorta becomes overriding. And this is the fourth thing. So as you can see here, the Tetralogy of Fallot, all those four things are in fact secondary changes caused by one single congenital anomaly, which is hypertrophy and deviation of the outlet septum of the right ventricle. And all the other things are just secondary. And this is what defines Tetralogy of Fallot. There is a question because there is a lot of Fallots. We've got Pathology of Fallot, which includes also ASD. We've got Trilogy of Fallot that includes the pulmonary stenosis, hypertrophy, and ASD. We've got even Hexalogy of Fallot. Is it really necessary? Does it really matter? Well, I don't think so. I don't think so because the definition of Fallot is clear. It's the deviation of the septum. And all the other things are secondary, and it doesn't say anything about the rest of the heart. So it can be associated with basically anything. So I think there is a really no need to exclude some pentalogy or hexalogy or heptalogy. So this is just a small note about the terminology, because the definition of the Fallot is quite clear and it can be associated with anything else. So there is really no need to include pentalogy or trilogy or hexalogy. And there is one disease. There is one disease which is very similar to the Tetralogy of Fallot from the both morphological and the clinical point of the view. And it is double outlet right ventricle. What does it mean? It means that the both great arteries, aorta and pulmonary trunk, originate from right ventricle, morphologically right ventricle. If we will be really exact, so the exact definition is that the more than 50% of the diameter of the both arteries originate from the right ventricle. This 50%, that's a border, there's a threshold between overriding and double outlet. So if the aorta opens from the right ventricle in less than 50%, it's overriding aorta. And if the aorta opens from the right ventricle in more than 50%, it's a double outlet right ventricle. So here you can see that the disease can be very similar from the morphological point of the view to Tetralogy of Fallot. There is almost always VSD. There's almost always a ventricular defect, which can be situated below the aorta, below the pulmonary trunk, somewhere in the middle, or it can be completely non-committed. This has its own clinical significance, and I will try to explain why. So imagine the course of the blood. Deoxygenated blood from the venous circulation goes to the right atrium, then into the right ventricle, and then it goes to the aorta as a venous alloy. So that's why it behaves like a Tetralogy of Fallot. And then it goes also into the pulmonary arteries, to the pulmonary circulation, back to the left ventricle, and to the defect. And then it has tendency to continue to the artery below which the defect is situated. So in this situation, the oxygenated blood from the left ventricle continues to the aorta, or mostly to the aorta, which is basically a good thing. But in this situation, the oxygenated blood from the left ventricle goes back to the pulmonary arteries and back to the lungs. So this subtypes harbors much higher overload of the lungs. So that's why it behaves clinically a little bit different. And that's why it was a little bit excluded from this category, and it's called Taussig-Bing anomaly. So this is something slightly different. Double outlet ventricle, it's quite commonly associated with other much more complex malformations like isomerism, for example. And it looks like this. This is one from the explanted heart. This is explanted heart. Here you can see the artificial valve because there was an insufficiency of the tricuspid valve. And look how big and thick the ventricle is. There's a huge hypertrophy of the ventricle. So this is the artificial valve. There is the rest of the tendons, which were dissected by the surgeon. And here you can see the origins of the both great arteries. So this is the aorta because there is a coronary artery. And this is a pulmonary trunk. And here you can see multiple VSDs. There are multiple ventricular defects that are hiding. And there is a rudimental left ventricle, which is really, really small. And I had to actively search for it because there is no outlet. Okay, so let's leave Tetralogy of Fallot and double outlet ventricle, and let's discuss a little bit the anomalies of the great arteries. Now we will discuss the common arterial trunk, or we can say persisting arterial trunk. What does it mean? As you all know, in embryology, during the development of the heart, there is one single artery that originates from the primitive ventricle. And then there is a septum growing into the lumen of the large artery, and it separates it into two, into aorta and pulmonary trunk. If this fails, we've got common or persisting arterial trunk. So there is one huge artery going from the ventricles. So there's a single artery leaving the heart. And since the aorta and pulmonary trunk are both defined by their branches, aorta is defined by coronary arteries and the big arteries for the head and neck and upper limbs, and the pulmonary trunk is defined by pulmonary arteries. The common trunk is defined by the both. So in case of common trunk, we've got one big artery that gives rise to both coronary arteries, large arteries for head and neck and upper limbs, and pulmonary arteries. This common trunk is usually overriding, so usually it sits somewhere in between the left and right ventricle, and there is one single valve, which is almost always atypical. There is almost always some sort of dysplasia of the valve, and there is almost always VSD. We've got four subtypes of common trunk, which was subclassified according to appearance of the pulmonary arteries. In case we have one common trunk, which then divides into pulmonary arteries, it's called type A. Type B has separate origins, but close to each other. Type C has two origins, which are more far. And type 4 has pulmonary arteries originating from descending aorta. However, during the course of the time, we realized that this fourth type of the common trunk is not a common trunk at all. We realized that this fourth type is the aorta. It's aorta, so this case is in fact the agenesis of pulmonary artery. So this is the agenesis of pulmonary artery, and this large artery is in fact aorta. And those so-called pulmonary arteries are in fact dilated systemic collaterals, which is the only chance for the blood how to get back to the lungs. So that's why this fourth type of common trunk was excluded, and now it is called solitary trunk, because we realized that this is not a common trunk, but it's aorta. And the pulmonary artery, the pulmonary trunk is missing. There's agenesis of pulmonary trunk, and those so-called pulmonary arteries are in fact just the systemic collaterals. It looks like this. So this is the heart with the common trunk. You can see that this is the heart is globoid. There is a dilatation of the heart. There's a right atrium, left atrium, and they are juxtaposed. They are close to each other. You can see that the right atrium has a quite typical morphology, and the left atrium has a typical morphology as well, which is thin and narrow. And there is a one big artery in between. And if we look inside the heart, we can see the atrium. There is ASD. This is the coronary sinus. And here you can see the tricuspid valve and dilated right ventricle. So tricuspid valve. And there is a VSD in the deep. So there's a ventricular defect. When we look into the left ventricle, we can appreciate the bicuspid valve, which looks quite okay. But look how dilated and how thick the left ventricle is. There is a severe hypertrophy of the left ventricle with a globoid dilatation. And here you can see the common artery. There is a common valve, which is dysplastic. You can see it's atypical and dysplastic. And there is one common artery that continues as a descending aorta, and it gives rise to the large arteries for the head and neck, but also pulmonary arteries. So this is the left pulmonary artery. So this is the common arterial trunk. And well, the common arterial trunk, it usually clinically, the clinical presentation is quite variable, because usually there is some sort of stenosis in the aortic or pulmonary part. So usually you've got some degree of stenosis of the arch itself, or you've got some sort of stenosis in the pulmonary arteries. So the clinical presentation is variable, and it depends on the degree of stenosis in the pulmonary or systemic circulation. And now let's discuss the transposition. What does it mean? If I use the scientific terminology, I would say that there is a bilateral ventricular arterial discordance. In a plain language, it means that aorta originates from morphologically right ventricle, and pulmonary trunk originates from morphologically left ventricle. The word morphologically is important here, because it says nothing about the position of the heart in the chest, because the heart can be variably rotated, or there can be even a mirror image of the disease. So it would be wrong to say that aorta is on the right side and pulmonary trunk is on the left side, because the heart can be rotated. So we should specify that the aorta originates from morphologically right ventricle, and pulmonary trunk originates from morphologically left ventricle, regardless its position in the chest. And if you imagine the flow of the blood, the deoxygenated blood from the venous circulation would go to the right atrium, then it would continue to the right ventricle and to the aorta and back to the systemic circulation. Oxygenated blood from the lungs would go to the left atrium, left ventricle, and then to the pulmonary trunk and back to the lungs. So in this situation, we've got two independent circuits, which is lethal, which the patient cannot survive this. So there is almost always VSD, which is necessary for survival, which ensures shunting of the blood. So you can see that the VSD, when we talked about VSD earlier, I didn't mention one important thing, and it is that sometimes the VSD can be, in fact, a good thing. In some situations, it can be even a life-saving change. And this is the typical example, because without VSD, this is the lethal disease. And in rare cases, the VSD is missing, and the communication between the ventricles needs to be created artificially, surgically, or better to say, by catheterization. What's also important to mention that there is often anomalous course of the coronary arteries. I will describe it in a minute. The problem of this disease is that it's often accompanied by other changes, especially in the left ventricle. In the left ventricle, there are almost always some sort of fibrous rings or muscular ridges that aggravate the disease. So this disease is not only about the transposition of the great arteries. This is in a lot of cases there are additional malformations that can aggravate this disease clinically. And speaking about the coronary arteries, we should realize that a lot of congenital malformations is often accompanied by anomalous courses of the coronary arteries, which we should keep in mind. And this is a typical example, because if you look at the arteries, those are the arteries in transposition. And if I go back to physiological anatomy, aorta or aortic valve and pulmonary valve have three cusps. Aorta has a left, right, and dorsal cusp. Pulmonary trunk has a left, right, and anterior cusp. But if you look at those arteries in transposition, this is the aorta, and we've got right, left, and an anterior cusp. So in case of transposition, the arteries are not just switched, but they are also rotated in 180 degrees. And this is often followed by anomalous course of the coronary arteries. The coronary arteries can go behind the pulmonary trunk. It can go intramurally. This is the intramural course of the coronary artery. And this is quite important information, especially for the surgeons, because the typical corrective procedure of transposition is so-called arterial switch, which means that the surgeon cuts away the piece of the pulmonary trunk, cuts away a piece of aorta, switch them, and the disease is solved. But the surgeon needs to be really aware of the very frequent anomalous course of the coronary arteries, which he or she could damage. Also, it's quite important in case of so-called Ross procedure. It's the same situation. So this we should keep in mind. And then we've got something similar, which is called congenitally corrected transposition. So where's the difference? Again, if I use a scientific term or scientific explanation, I would say that this disease is defined by bilateral atrioventricular and ventricular arterial discordance. Again, in plain language, it means that the right atrium is followed by left ventricle and then pulmonary trunk. Left atrium is followed by right ventricle and then aorta. So if you look at this heart, try to imagine the flow of the blood. The deoxygenated blood from the venous circulation goes to the right atrium, to the left ventricle, and then to the pulmonary trunk. It's oxygenated in the lungs, and then it continues into the left atrium, right ventricle, and into the aorta and systemic circulation. So, in fact, the heart is okay. The heart works normally because the blood flow is normal. So that's why it's in fact just the inversion of the ventricles, but the ventricles can adapt to the different pressures. So that's why this disease is called congenital corrected transposition, because the heart is, let's say, corrected and the blood can flow in normal way. But the real situation is much more complicated because there are almost always some additional malformations that, let's say, discorrect the correction. Pulmonary stenosis is quite common. VSD is quite common. And there is very frequently a malformation of a tricuspid valve, which is very similar to Epstein malformation, and we call it Epsteinoid malformation. So even if the heart looks corrected at the first glance, in reality, there is usually some sort of additional malformation that aggravate the disease. Also, what is important to mention, the heart can be corrected morphologically, but it is definitely not corrected functionally, because there is something we call conduction system. And that's another thing we should keep in mind, that a lot of cardiac malformation that may seem simple from the morphological point of the view can be quite severe from the functional point of the view, because the conduction system can be somehow malformed. And this is it's the situation of the congenitally corrected transposition as well, because due to inversion of the chamber of the ventricles, the conduction system goes in completely different way. And I will try to explain it a little bit. Again, this is the view on the heart from the top. This is the frontal, dorsal, left, and right. So this is the normal heart. So we've got a right ventricle here with the tricuspid valve. This is the left ventricle with bicuspid valve. This is a pulmonary trunk and aorta. And there we've got the AV node, which continues to the bundle of His, which sits on the top of the crest of the interventricular septum, and then it branches into two branches of Tawar, left and right. So this is the normal situation. But in case of corrected transposition, the conductive system is completely malformed. The AV node is very often divided into two, as a dorsal and ventral node, and the bundle of His is very long, because it needs to bypass the whole left ventricle, which is situated on the right side. And after that, it branches into branches of Tawar. So here you can see that the malformation may seem to be corrected from the morphological point of the view, but it is definitely not corrected from the functional point of the view, because the conduction system is often malformed. And I think the last disease I will mention, we've got last few minutes, is coarctation of the aorta. So what does it mean? Coarctation of the aorta is narrowing of the aorta. It's usually in the proximity of the arterial duct. Just a small reminder, there is a difference between coarctation and atresia, because atresia is complete occlusion of the arterial lumen. So there is just the thin fibrous band instead of aorta. And interruption is a state in which a part of the aorta is completely missing. It's completely interrupted. It's usually in the aortic isthmus, which is the segment between left common carotid and the left subclavian artery. But coarctation is a narrowing. Usually it looks like this. We've got the waist in here, but we can have also a complete hypoplasia of the large portion of the aortic arch, which we call tubular hypoplasia. Or we can have very rarely we can have a membrane which occludes lumen of the aorta from the inner view. And it is quite important to subclassify it as a coarctation without and with patent arterial duct, because those two groups represent completely different malformations. If the arterial duct is missing, this coarctation is usually an isolated defect, which is often found in older patients, and it is a result of a retraction of the arterial duct. As the arterial duct retracts, it pulls the aorta and creates waste. But in case of patent arterial duct, this is the much more complex malformation. It's usually found in the small children, in newborns. Usually it's a preductal. Very rarely it's postductal, and some surgeons even speculate if this type exists. But what is important, that this is caused by atypical connection between arterial duct and aorta, because in normal situation the connection has a shape of V or arrow. So when I use the surgical terminology, I would say it's a side-to-side anastomosis. But in case of coarctation, the ducto-arterial connection has a shape of T. So it's more like end-to-side anastomosis. And this leads to the coarctation. And what is important that this sort of coarctation is often part of the more complex heart malformations, typically hypoplastic left heart syndrome. So in these cases, there is a complete hypoplasia of the left part of the heart, which is often accompanied by coarctation. And in these situations, the coarctation is often of a tubular type. So there is a complete hypoplasia of the whole arch. So that's why this disease is usually, the prognosis of this disease is very often worse. And it looks like this. This is just a short video. Here you can see the aortic arch with the branches. And here you can see that this part is much more narrow. So this is the preductal coarctation, because compare it with the size of the ascending aorta. And this is the pulmonary chunk. And the interruption, as I said, that's the complete absence of the segment of the aortic arch. And it looks like this. So this is the ascending aorta with the branches. This is the pulmonary trunk. Aorta again with the branches. This is the right subclavian artery. And in this region, the aortic arch is missing. And it continues here as a descending aorta. So this part is a pulmonary trunk. This is the arterial duct. And this is the rest of the aorta. So at the first glance, this disease may look like a transposition, but it is not. It's just interruption of the aortic arch. Okay, well, I think our time is up. In case we had more time, I would have one more malformations, which would take us, let's say, 5 minutes. And I consider it quite important, but I don't want to flood you with the malformations. So we can leave it here, or I can continue for a few minutes. So it's up to you.
I think we definitely want to hear the bonus round. I think we have time.
Okay. So give me just a few minutes. I decided to include, at the end, functional univentricular circulation, because I think this group of diseases may be a little bit complicated for understanding, but it is not rare. So that's why I wanted to speak about it at the end. The word functionally is essential here, because the heart with one ventricle, it exists, but it's very, very rare. Usually, the heart has 2 ventricles, but 1 ventricle is somehow excluded from the function. So the heart, even if it is morphologically biventricular, it's from the functional point of the view, it behaves like univentricular. And we've got several situations here. We can subclassify it as a heart with univentricular IV connection, which means that there is just one connection between atria and ventricles, which can be in case of double inlet ventricle, not outlet, but inlet, or in case of atresia of the AV valve. And the second situation is that we've got biventricular connection, which means that we've got 2 connections between atria and ventricles, but from some other reasons, 1/2 of the heart is excluded from the function. So the double inlet ventricle means that the both atria opens into one single ventricle, which is usually left. And very rarely it's a right or indeterminate ventricle, but it's usually left ventricle. There can be 2 separated ostia or just one AVSD. And it doesn't tell us anything about the rest of the heart. So it doesn't tell us anything about the position of the great arteries, which can be normal or in transposition, or this ventricle can be even double outlet. And the second situation is atresia of the AV valve, because if you have atresia of the tricuspid or bicuspid valve, it excludes the one ventricle from the function as well. Usually it's a tricuspid valve. Again, just small vocabulary. there is a difference between atresia and imperforation, because imperforation means that the valve is present, but there is no ostium. But atresia means that there is a complete absence of AV junction. There is a complete absence of fibrous annulus, and during autopsy, you can very easily lift atrium from the ventricle. The same situation can happen in case of atresia of aortic or pulmonary valve, but in this case, you need to have intact ventricular septum, because if you had a VSD, for example, it would allow shunting of the blood. But in case you have, in a vast majority of the cases, it's the pulmonary atresia. Aortic is much more rare. If it is pulmonary atresia with intact septum, it behaves again as a univentricular circulation. However, those atresias of the valves are very often a part of the complete hypoplasia of the whole right or left part of the heart. So they are very often part of so-called hypoplastic left or right heart syndrome. So the hypoplastic left heart syndrome is much more common. So it looks like this. The atrium is usually smaller, but not too much. But the bicuspid valve, the mitral valve, is atretic or at least severely stenotic. There is usually severe hypoplasia of the left ventricle, usually with a prominent fibroelastosis. And there is often aortic stenosis, and there is often a coarctation, usually of the tubular type, as I mentioned before. And the hypoplastic right heart syndrome is the same for the right heart. And I will finish it with 2 short videos, and that will be all. So this is the hypoplastic left heart syndrome. So this is the right ventricle. This is a very small heart. It's a fetal heart, but this is the quite normal right ventricle. It's a little bit hypertrophic, but that's so. This is the AVSD. So this is the right ventricle, which is quite large. There is a tricuspid valve. And this is the outlet portion with the pulmonary valve, which looks quite okay. But when we look at the left ventricle, it's much smaller. So there's a hypoplasia. This is not so severe. Usually we see much more severely hypoplastic ventricle. So this ventricle looks quite good, but still it's smaller and hypoplastic. There's a parachute mitral valve. There's a parachute bicuspid valve. And yeah. And I think there should be coarctation as well. So this is the ascending aorta. And oh yeah. So there's a coarctation because you see that this segment is much thinner compared to the ascending aorta. This is the picture of the hypoplastic left ventricle. You see how severely hypoplastic the ventricle is. There is this is called Sano shunt, because it's a part of Norwood procedure. It's a multi-step procedure in which the heart is corrected. So just a reminder, this is called Sano shunt, which ensures flow of the blood from the single right ventricle to the pulmonary circulation. There was aneurysm of the shunt, which was thrombosed, and it was the cause of the death. And this is the last video. This is the hypoplastic right heart syndrome, and you can see this is the superior vena cava. There is some weird connection between the pulmonary circulation, but here you can see the right atrium, right appendage. The video is not sharp enough, but there were fenestrations in the membrane, in the valve. But here you can see the severely hypoplastic right ventricle with severely stenotic tricuspid valve. And this is the pulmonary trunk. And you see that the valve is almost completely occluded. It is not fully atretic. There is a tiny lumen which I can probe. So there is a severe stenosis of the pulmonary trunk. And the rest of the pulmonary trunk is dilated. It's quite wide. So there is a post-stenotic dilatation. This is the typical disease that comes in a Noonan syndrome, for example. And this is the left ventricle. You see how large it is. It's a severely hypertrophic because it needs to work for two circuits. So there is a severe hypertrophy of the left ventricle. There's also a little bit of bulging of the interatrial septum. So maybe there was clinically some sort of subvalvular stenosis. But the aorta looks quite okay. It's quite wide. So this was hypoplastic right heart syndrome. Okay, that's all. That's all from my side. I really thank you for your attention, and I will just. Okay, so thank you for your attention, and I am open for the discussion, and I try to switch off the screen. So thank you.
Saranya, you should unmute.
Yeah,
you
Sarah,
are muted.
I'm so sorry, and I will go again. Thank you so much for that lecture, Ondrej. It was definitely not an easy task to summarize the entire spectrum of congenital lesions well within 1 hour. And I think you have done an excellent job. This was actually our first lecture on congenital heart. And I think it was an excellent introductory lecture. I also very much enjoyed your original drawings, photographs, and videos. I would like to now invite our panelists to ask if they have any comments or questions.
I would just like to make a comment.
Yep.
The usual way in which we would put together the Fallot's tetralogy, the DORV, transposition, and truncus, they would all come in the category of conotruncal anomalies. Because the anomaly there is basically related to the conal or the outlet septal.
Yeah, definitely.
Yeah. So our way of approaching would be, especially when we are teaching, we would put it under the bucket of conotruncal anomalies. And there is often, difficult decision regarding Fallot's and DORV, particularly when there is a lot of rotation of the aorta and a lot of overriding of the aorta and a subaortic VSD. The question arises, is it a DORV or is it a Fallot's tetralogy? And what we look for generally is aortic mitral continuity or discontinuity. Now, in normal hearts, we have a fibrous continuity between the mitral leaflet and the non-coronary cusp of the aortic leaflet, and which is preserved in Fallot's tetralogy. So the aortic mitral continuity, fibrous continuity is maintained in Fallot's tetralogy. But in a DORV, subaortic VSD, we would have a bit of the muscular infundibulum separating the aortic valve from the mitral valve. So there is a discontinuity between the mitral and the aortic valve. Of course, it is not, if you have a gross specimen, it is often possible to identify, though it may be a minuscule little band. It is difficult to make this out in echos and their various planes. But as morphologists, we look at the aortic mitral continuity or discontinuity to differentiate between a Fallows or a DORV. I mean, for us, see, it is a theoretical uh, discussion based on the amount of infundibular septum malalignment. But for the surgeons, I guess this 50% rule is okay as far as their correction procedures are involved, because it would depend upon the how much of how they are going to do the orientation of the aorta to the left ventricle and the pulmonary artery to the right ventricle. So this is the way at least we have been taught or trained to look at the aortic mitral continuity or discontinuity to differentiate between the TOF and the Fallows, DORV.
Yeah, thank you very much for the comment. I totally agree because well, I used the terminology from pathological anatomy, but you are definitely right that practically it's very difficult to assess the shape and appearance of the outlet septum or to assess whether the overriding is less or more than 50%. So this discontinuation of the aortic and mitral valve is definitely helpful. And sometimes we can see both. Sometimes we can see both diseases combined together, and by the clinicians is often called double outlet right ventricle of Fallot type or something similar. So yes, definitely I agree with you.
We have a question from Martin, and he's joining us from Hungary, and he wants to know, how do you find the separated AV node? Is there a typical localization of the nodal structures?
Well, I have never saw it by myself because I have never done a research with special interest in the conduction system. But well, the separation of the AV nodes is not a rule. It's quite common, but it's not a rule. But the AV node is always misplaced, and the normal physiological localization of the AV node is in so-called Koch's triangle. But in case of transposition, the AV node is displaced into something we call nodal triangle, which is a little bit more to the dorsal side of the right. So let's say the localization of the AV node in case of transposition is defined. So it can be found, and we call this region nodal triangle. But as I said, from my side, it's just a theoretical answer.
Are there any more questions from the panel?
As regards VSD, as you mentioned, perimembranous VSD is the most common type of VSD. And the surgeon is often worried about, the conduction system and its relation to the margin of the VSD. And in that, what is important is in which direction the VSD is pointing. The VSD can point towards the outflow. It can point towards the apical part of the right ventricle, or it can be a little horizontally placed under the tricuspid septal deflects. And based on these three locations, the conduction system will be oriented accordingly. So if the if the VSD is more under the tricuspid valve horizontal, then the conduction system is quite far away. I mean, the surgeon has a good margin of the muscle bundle to put his sutures inside. But it's very important anatomically also to identify the subtype of perimembranous VSD? Is it pointing towards the outlet? Is it pointing towards the apical part of the right ventricle, or is it a little horizontally placed? Accordingly, the conduction system, the right bundle branch block will course along the margin of the VSD.
Yeah, definitely. Thank you again for the comment. Totally agree.
Are there any more comments?
Excellent videos.
Excellent videos. Yes, I agree, ma'am.
And very nice pictures. I'm sure those hearts must have been very, very tiny.
Well, yeah, I think that's the common problem, especially in our region of the world and our countries, because, for example, Czech Republic has a long tradition with dealing with congenital heart diseases from the surgical point of the view, and the diseases we face now as a pathologist, they are usually very complex because the lot of, let's say, normal diseases, normal malformations are diagnosed prenatally and surgically corrected postnatally with a high success rate. So we have to deal with usually much more complex malformations in very small children. In a lot of cases, they are fetal hearts, and in a lot of cases, we need to deal with partially or completely surgically corrected hearts. So we need to be able to orient ourselves also in the operated terrain. So that's why we don't see Tetralogy of Fallot, for example, anymore, because it's very well diagnosed prenatally, and the success rate of the operation, it's almost 97 or 98%. But we deal with univentricular circulation, we deal with isomerism, or things like that, or we deal with the heart from the fetus, which is 20 weeks old. So that's why it is so complicated nowadays.
I just wanted to ask one question. The concept of monology in tetralogy, can it be also applied to the so-called triology which you said? Because in that triology, there was absence of VSD. So is the same embryological concept applied even to that so-called triology?
Well, from the purely from the morphological point of the view, I would say it all depends on the presence of the typical malformation of the outlet septum. If it is in there, I would put it into the category of a Fallot, but it depends on the septum. There is a one disease which is very similar, but it's excluded from the category because there is no typical subpulmonary stenosis, and it's I think it's called Eisenmenger's septal defect, something like that, which is very rare. But with regards to the question, from the purely morphologically point of the view, I would say if there is a typical septal malformation, I would include it into this category.
Okay, thanks.
I have a question. I would like to ask you for a commentary. What is the role of imaging techniques like CT, ultrasound in this area? Are they helpful? What are their disadvantages? How they can help us? Can they replace us in the future?
I'm pretty sure they will replace us, and they are definitely helpful because I don't want to say in all of the cases, but in the majority of the cases, we have at least a simple description of echocardiography before the autopsy. So it's very helpful for us because it helps us to orient ourselves, especially in the surgical corrected malformations, and we can compare it with the echocardiography, because still, even in this time, according to the studies, the assessment of the heart by pathologists is still a little bit more precise method than echocardiography. But definitely, when we face the autopsy of the heart with the congenital malformation, we require echo findings if they are available. But as I said, it's not always the rule, because this is problem especially for the smaller local pathology departments, because sometimes, at least in our country, mother is diagnosed, or let's say her baby is diagnosed with congenital heart disease in utero, and interruption is recommended, but the mother goes for interruption into the local city where the mother lives. So sometimes it's done at the periphery, and the pathologist at the periphery in some small department faces the congenital malformations, but he or she lacks the proper expertise of the morphology of the heart diseases, and also there is often lack of clinical information, clinical data. So sometimes it can be a problem, especially in smaller pathologists, but if it is possible, we require echocardiography.
How about CT, computed tomography? Do you have experience with that?
Not too much, to be honest. Not too much. Usually we deal with echocardiography. That's my experience.
Yeah, thank you.
Are there any more comments or questions? Pranita, were you able to take a look at the Facebook group?
She's unmuted. She's muted herself.
I don't think we have any questions on Facebook at the moment. So are there any more comments or questions from the panel? All right, so I think we end the session here then. Thank you once again for joining us and for a wonderful lecture. And, I think we plan on having more lectures on each of the individual malformations starting next year. So it would be wonderful if you could come back for that as well. And yeah.
Yes, sorry, continue.
And before we leave, I would like to wish everyone in India a very happy Diwali. And, thank you for taking time. And, I can just start to hear the firecrackers. So, that's about to begin. So anyway, thank you so much for joining us here today. And we meet again in 2 weeks, where we will be remembering Dr. Suman Kinare, who founded the specialty of cardiovascular pathology in India. And we will be celebrating her life and her work, and we will be talking about non-specific aortic arthritis. So it would be really good if everyone could come back for that as well. Thank you so much, and good evening.
I thank you again for inviting me. It was a pleasant time that I spent with you, and happy Diwali, and I will be happy to see you in the future. So
yes.
Thank you very much, and goodbye.
Thank you so much.
Happy Diwali. Thank you.
Thank you.
Bye. Bye.
Thank you.
Happy Diwali to you.
Thank you.